So good afternoon, everyone. Good afternoon, goodness. Tough crowd, my goodness.
Tired.
You tired? What you been doing? Who said that? What you been doing?
Been here all day.
Oh, I understand. I know you're ready to explore the Big Easy. Is that it? No.
Betcha.
Oh my goodness. Well, good afternoon again. Thank you all for being here for our session on advances in kidney care for people with sickle cell nephropathy. And I am Tangela Purnell, an associate professor of epidemiology and surgery at Johns Hopkins University. And it is indeed my pleasure to welcome our two presenters for today. So we'll start by introducing Dr. Chancellor Donald, who is the counselor in clinical practice for the American Society of Hematology. He currently is an assistant professor of clinical medicine at Tulane University and is also medical director for the Tulane Cancer Management and Oncology Services. He is also faculty at the Louisiana Cancer Research Center in the Population Sciences program. Sorry, there are gnats flying. There are gnats flying around if you see me move me. Okay, so he's also faculty. His academic focus is advocacy and health disparities regarding patients with hematologic disorders and also cancers. And he is in case he wasn't already busy enough, Dr. Donald is also president of the Medical Executive Committee at the University Medical Center in New Orleans and is appointed to the Board of Trustees of LCMC Health. He currently also serves on the American Board of Internal Medicine's Hematology Examination Approval Committee. And we would like to welcome him here for, I believe, his very first National Kidney Foundation meeting. So thank you for coming. We also have Dr. Vimal Darabel. I got it, okay. I was practicing, you all, who is an adult nephrologist and also a professor of medicine at the University of North Carolina at Chapel Hill. His practice is focused in the care of patients with glomerular diseases and vasculitis, as well as managing kidney disease in patients with sickle cell. He also collaborates closely with other physicians and basic and translational scientists studying glomerular disease and vasculitis, as well as those studying sickle cell disease and sickle cell trait. In addition to this, he maintains a dedicated multidisciplinary sickle cell kidney disease clinic with colleagues in the Division of Hematology at UNC, and has had multiple research collaborations in the US and internationally, including a current clinical trial, right? Or a potential. Oh, sorry. Okay, so with that being said, well, other very closely related research and perhaps heavily guarded research, so my apologies for that. With that being said, we will start by reminding you to please take a look at the app and use it to submit your questions. Also, NKF has asked me to remind you all to please let people on social media know if you are enjoying the meeting, which I'm sure you are. If you're enjoying it so much that you're tired and you're looking forward to partying in New Orleans, that's fine too. I think it could bring people out. And also, so after approximately 20 minutes of discussion each from the didactic piece, we will then invite both of our speakers up to join us for a panel discussion. So again, want to invite you to input your questions through the app, or later you would be invited to come up to the mic. And with that being said, please, let's get started. Thank you.
Good afternoon. Thank you guys for attending today. This morning I woke up and I was checking to see what time this session was because I have OCD and was panicking about it. And I was still in North Carolina this morning, so it told me it was at 5 o'clock, and I didn't realize the app adjusted for time. So I thought, at 5 o'clock, this close to Bourbon Street, nobody's coming to this session. So I'm glad you guys were able to attend today. With that, as Tangela mentioned, I'm an adult nephrologist at UNC. I work in a sickle cell clinic with our sickle cell hematologists. We only meet one day a month, but we have a fairly robust clinic and have been following those patients for quite a while. And I thank the organizers for putting this session together, because I think this is a very unappreciated topic and one that's near and dear to my heart. These are my disclosures. And so learning objectives today, I'll talk briefly about what happens in the kidneys in sickle cell disease and how that manifests clinically. And with most of our systemic diseases that affect the kidney, this is a disease where we have to treat both the disease and the kidney and think about them a little bit separately, so upstream and downstream. And finally, we'll talk a little bit about how advanced kidney disease management in patients with sickle cell is somewhat different than in the general CKD or end-stage kidney disease population because of their other unique comorbidities. So sickle cell disease has a very complex pathophysiology. The classic teaching for years had been, bear with me 1 second, I just want to get my little pointer out here. There we go. The classic teaching had been that sickling of red blood cells in the vasa recta would cause chronic ischemic changes and lead this sort of feedback to the glomerulus, mediated mostly by prostaglandins, leading to hyperfiltration, eventual sclerosis and FSGS and proteinuria. And that's sort of been the predominant theme for how we think sickle cell disease affects the kidney, and that's probably partly true. And that is why we do see proteinuria and albuminuria in the patients with sickle cell disease. However, it's also a systemic disease, so there is also chronic ischemic changes elsewhere, and hemolysis, which leads to free heme and reactive oxidative species being produced, which also affect the kidney, both in the glomerulus and in the tubular compartment. So we do see changes, not just albuminuria and proteinuria, but we also see these changes in the proximal tubule with resorption of phosphate, importantly, hypersecretion of creatinine and uric acid, and decrease in ammonia production, so more prone to acidosis. In the distal nephron, we can see injury to the kidney leading to hematuria. There's impaired urinary concentration because of the changes to the vasa recta. And so there are a lot of these changes that manifest in the kidney beyond what we've typically considered. The histopathology of kidney disease also reflects that complex pathophysiology. So classically, the proteinuric lesion of sickle cell disease was described as an FSGS lesion, primarily a perihilar FSGS. But there's also been a descriptive of membranous proliferative glomerulonephritis, now thought perhaps to be related to infections acquired during the time of transfusion prior to viral screening, but also described in other situations as well. Red blood cell congestion can occur in the glomeruli, leading to ischemic changes in the glomerulus. And often we just see glomerular enlargement as an early feature, along with mesangial hypercellularity preceding that secondary FSGS lesion. Because of the hemolysis and free heme floating, we see hemosiderin deposition both in parietal epithelial cells in the glomerulus, as well as in the tubular epithelium. And consequently, that does lead to tubular atrophy, interstitial fibrosis, and this sort of blunting of the brush border, consistent with that proximal tubular dysfunction. As I mentioned, one of the issues in the proximal tubule is we have this hyperfiltration of hypersecretion of creatinine. And since we base most of our GFR estimates on creatinine, it's not very straightforward in sickle cell disease. And this is a really nice review written by Santosh Saraf over at UIC in Chicago, looking at a variety of different studies that have compared estimating equations of GFR indexed against measured GFR in patients with sickle cell disease. And nearly universally, all of these equations we use tend to bias and overestimate eGFR, with probably the least bias seen now currently with the CKD epi cystatin C-based equation. Interestingly, in these studies, if you take that cystatin C equation, you add creatinine back into it, you lose the fidelity of that equation, so it actually makes it worse. In the pediatric population, the Schwartz cystatin C equation has sort of become the predominant one just because it's most commonly used in that population, and it works fairly well and much better than the older Schwartz equation, the C-KIT equation, pardon me, not the Schwartz equation. But again, also biased by those pediatric estimating equations. Nearly universally, we see in all of the cohort studies of sickle cell disease that eGFR loss is accelerated in sickle cell disease. And this is, again, a nice compilation of all the variety of studies who've looked at slope of eGFR and natural history studies of sickle cell. And you see that this approaches 2 to 3 mLs in patients per year in patients with with severe forms of sickle cell disease, hemoglobin SS disease, or beta zero thalassemia. And when we compare that to non-sickle cell populations, this is close to the same rate seen in patients with diabetes in the CRIC study among Afro-Americans and in the untreated arm of the AST study. So pretty substantial loss of kidney function across that board. As I mentioned, albuminuria is one of the early features of sickle cell disease, and what precedes that is hyperfiltration. This is a nice natural history study of a pediatric population out of UAB, where they looked at the patients who had persistent albuminuria versus those who had intermittent albuminuria or no albuminuria. And those who went on to demonstrate persistent albuminuria follow this, what we think to be the natural history of sickle cell disease, where you have this increasing hyperfiltration over time, and this is actually by measured GFR. And then over time, it starts to drop again. And the difficult part is this is probably not an improvement in hyperfiltration, but more likely loss of kidney function, bringing that GFR back into a normal range. Trying to define where to intervene in this population is still unclear. Current guidelines recommend screening patients at the age of 10 for albuminuria, but there are clearly patients who develop persistent albuminuria below the age of 10, particularly if they have APOL1 high-risk genotypes. And just like with most of our other kidney disease, APOL1 high-risk genotypes confer a greater risk of kidney disease and loss of kidney function in this population. That persistent albuminuria, as I mentioned, what we've now seen both in that pediatric study and in this adult study is that if you screen patients, often albuminuria is so variable, and even more so in the sickle cell population, that they may have small amounts of albuminuria in that 30 to 300 range, but it may not persist. They may follow a crisis and have that detectable, but whether intervention is warranted there is still unclear. What we have seen is those patients who have albuminuria at any time that is over 100 milligrams per gram creatinine, they are a much greater risk of having persistent albuminuria over time, and that is associated with a loss of GFR. Notably here, if you look at this y-axis here, these again GFR losses from 150 to 130, so still not in the range of CKD in this 2-year study, but over time we do think this translates down to worsening kidney function. So what do we do about this? Like with any other proteinuric kidney disease, our mainstay of therapy has been ACE inhibitors and RAS blockade. I like to quote this study because it's from my boss, Dr. Falk, which dates back to 1992 from the New England Journal. I think it's the only study in the New England Journal that has 9 patients in it, but it's a short-term study of captopril demonstrating that after 2 weeks of treatment, you see an improvement in proteinuria in sickle cell patients, which rebounds once you pull off the captopril. So this is one of the first studies to really demonstrate that. This is the closest thing we have to a randomized control trial of ACE inhibitors in sickle cell disease. Again, a relatively short-term study over 6 months, but comparing captopril to placebo, there was an improvement in albuminuria and no worsening of albuminuria over that period of time. Similar data for angiotensin receptor blockers, and there are some sickle cell hematologists who prefer this over ACE inhibitors for not necessarily clear reasons per se, but certainly by practice. And so this is a study over 6 months of losartan, and patients with micro or macroalbuminuria, as we used to call it, had benefit in their proteinuria, albuminuria with losartan treatment. Another study has followed that up, looking at a longer term out to 12 months, and again demonstrated a reduction in proteinuria. There are lots of gnats up here, you're right. Yeah, it's not just you, yeah. That long-term benefit of ACE inhibitors is really still not clearly well understood in sickle cell disease. This is a study from one of our cohorts looking at a retrospective study from our sickle cell patients. So those treated with RAS blockade matched to those patients who weren't treated with RAS but looked similar. And in that, the patients who were treated with RAS blockade had much slower loss of GFR over time, but again, fairly rapid GFR loss. But the untreated group had GFR loss approaching 4 to 5 mils per minute per year. Hydroxyurea, if you're not a hematologist, you probably haven't thought about this drug in a long time, but this is one of the mainstays of treatment for sickle cell disease, and again has been implicated as potential therapy to help with albuminuria, sort of treating the underlying disease again. And again, not a lot of data to support its use just for albuminuria. This first study is a cross-sectional study out of one of our sickle cell cohorts again, looking at hydroxyurea use, and if patients were on hydroxyurea, they had a much lower odds of having albuminuria. Again, a cross-sectional study, not prospective. This is another small-term prospective clinical trial that was done adding hydroxyurea to patients already on ACE or ARB. And there was a small improvement in albuminuria in patients treated with hydroxyurea after 6 months, but that improvement was really seen in the patients who had what they described as microalbuminuria, so that 30 to 300 milligrams of albuminuria range, suggesting that perhaps if you're going to do this, you need to intervene early, and if you wait too long, the horse is out of the barn. One of the things that has been complicated by this issue of estimating GFR is really understanding when patients with sickle cell disease may manifest complications of chronic kidney disease. And again, this is a study out of Chicago that compared patients from a pulmonary hypertension cohort called the Walk Fast study to NHANES. And if you look across categories of eGFR, the likelihood of hyperkalemia or metabolic acidosis is greater in the sickle cell population, regardless of where you are with GFR. And when we tried to map that out by an inflection point, really patients started exhibiting those features at a GFR of around 80 to 90, so much higher than what we would call CKD in our population. Again, it's not clear if this is happening because we're likely underestimating CKD because of our inability to estimate GFR very well in this population. But this does raise the question that if you see a GFR of 80 or 90 in a sickle cell patient, should you start thinking about referring to a nephrologist much earlier? What about the dialysis population? As you may expect, patients with sickle cell disease have a much higher mortality rate, and with 26% of patients dying within the first year of starting hemodialysis, so nearly a threefold increase from non-sickle cell patients. The majority of patients with sickle cell disease start without a vascular access, so typically with a dialysis catheter. However, if those patients were seeing a nephrologist, their mortality rate was reduced, so I think we provide some services. Long-term comparative mortality, so this is actually looking at 5-year mortality in a French cohort. At 5 years, that mortality was 46% compared to 6% in the non-sickle cell population. And again, this is against an age-matched control group, so often our patients who make it to dialysis with sickle cell are much younger than our general dialysis population, but have much higher mortality than that same age-matched group. Those patients on dialysis with advanced kidney disease and sickle cell have a compilation of other comorbidities, so we see much higher rates of pulmonary hypertension in that group as measured by TR jet velocity. They also have more hypertension, more likely to have flutter atrial fibrillation, congestive heart failure, infectious complications, DVTs, and they often require blood transfusions despite using EPO in the dialysis clinics. This is recent data from a large dialysis organization, and I say recent by about 5 or 6 years ago now published, but looking at 504 sickle cell patients with end-stage kidney disease. For context, if you look at the US RDS data, about 1% of the dialysis population in the United States has sickle cell disease. So it's a very, very, 0.1%, not 1%. So it's a very rare, it's a very small population to study, so this is that bulk of that population. As commensurate with what we see in the non-sickle cell population, only 6% of patients were on peritoneal dialysis, but comparative to the non-sickle cell population, there were higher hospitalization rates, higher mortality. And mortality was associated with anemia, and importantly, a couple things to point out: higher ultrafiltration rates, which we think could potentially precipitate crisis if you're hemoconcentrating the blood, and higher dialysate sodium, which also could potentially precipitate crises for similar reasons. Notably, there was a trend toward lower mortality in the peritoneal dialysis group, so just as we're underutilizing this in the general population, we're probably underutilizing it in the sickle cell population. Anemia in a sickle cell anemia patient is a problem even pre-dialysis, but once they start dialysis, it gets a bit more complicated. As most of you know, our dialysis clinics all have these algorithms to drive dosing of EPO to target hemoglobin levels. And thankfully, I've not seen this in a long time, but we have had patients who were overtreated, reaching hemoglobins of 11 or 12, and then and coming in the hospital with severe crises and thrombotic events. Have not seen that in a long time, thankfully. But there is concern that if we target that similar hemoglobin, could we precipitate crises or cardiovascular events? Currently, the American Society of Hematology suggests that the hemoglobin goal in patients who reach dialysis with sickle cell should be no more than 10 gram per deciliter. So just sort of capping at that rate, but realistically probably more in the 8 to 9 milligram per deciliter range. I think this stresses the importance of including the hematologist in the management of those patients. And for some of our sickle cell patients who are on dialysis, the outpatient dialysis physicians are willing to cede control of that EPO dosing purely to them so they can manage that, because it can be complicated and they often require massive doses, much higher than we use in our general dialysis population. Kidney transplantation, thankfully, does confer a survival advantage even in sickle cell patients. In this one study, 90-day post-transplant, after transplant, following those patients forward, they had a much lower mortality rate, but they are prone to more transplant complications. There is an increased frequency in crises early on, which is perhaps driven by enhanced erythropoiesis when you put in a new kidney that's able to make EPO again. There is a higher risk of allograft thrombosis and venous thromboembolism in the perioperative phase. And we really have no data for specific immunosuppression recommendations. As you know, a large proportion of the country is still using steroid-based immunosuppressive therapies, and steroids have been implicated as precipitating sickle cell crises, but more importantly, a lot of our sickle cell patients already have avascular necrosis from their sickle cell disease, so whether we're contributing to bone disease over time, we don't know. As mentioned, kidney transplant does confer benefit, and if you look at older data, there is suggestion those patients didn't do quite as well, but in the modern era, there has been an improvement in outcomes, so patients now achieving 70%-ish or so survival at 5 years post-transplant, and graft survival in that similar range. And if we compare that to the diabetic population, sickle cell patients perform about as well as a diabetic patient post-transplant, so not a reason not to transplant a sickle cell patient. There have been some suggestions about how to manage transplantation in sickle cell patients. These are not necessarily driven by data, but more by what we think makes sense. So exchange transfusion perioperatively, and maybe even suggesting to start exchanges when you think a patient is getting close to transplant so that they are protected in that way. Thought of warming the allograft to help reduce the likelihood of cold temperature, inducing sickling within the kidney, hyperoxygenation perhaps, as well as minimization of corticosteroids, as I mentioned. There's also maybe a role, at least from one study performed in France, to suggest that exchange transfusion for the first 6 months post-transplant may also improve graft survival out to 5 years. So summary, the kidney is particularly susceptible to injury in patients with sickle cell disease because of its low oxygen, high osmolality, and relatively slow blood flow through the renal medulla. Hyperfiltration and subsequent albuminuria are early manifestations of kidney disease and predict progressive loss of GFR. As we recommend screening for albuminuria in the young population, and maybe even younger if they have known APOL1 risk genotypes, or as a surrogate if they have a family history of kidney disease. We still need to understand better how to estimate GFR in this population, as creatinine-based estimation does not work as well. Cystatin C may perhaps work a little bit better. And then I think really important is considering early referral to the nephrologist. I think some difficulty here is that often nephrologists are not really sure what to say when they get that patient, but you'd be surprised how often just offloading hypertension management from the hematologist makes a big difference in their care, because they have to focus on so many other things for this patient population. I will say that, I think we've been fooled a few times with our patients, so that just because they have sickle cell disease doesn't mean they can't have other forms of kidney disease. So really still making sure that you've done a proper workup for that patient. We've picked up a few patients with IgA nephropathy and minimal change disease, surprisingly, who we had to manage very differently from the usual sickle cell nephropathy. Again, ESKD is associated with high mortality, but transplant is possible. It just requires a lot of close coordination with the hematology team, the transfusion medicine team, and willing transplant surgeons, but it is doable. So what lies ahead? I think we talked a little bit about how we treat the disease and treat the kidney. And in both of these settings, we have new therapies that have come forward, and this population has not been included in any of those studies, so we really don't know how any of these work. So within the sickle cell disease population, even though we have new agents available for sickle cell disease, not many of the patients included in any of those clinical trials had kidney disease or substantial advanced kidney disease, advanced loss of GFR. So we don't know if there's really any benefit to the kidney when we reach these therapies. There has been a big interest in the sickle cell community about looking at end organ disease because patients are living longer, and so now we have patients in their 50s or 60s, but they have pulmonary hypertension, they have kidney disease, they have all these other complications we have to learn how to manage. So one big push, I think, is to really say, you know, as these trials are happening, it's not hard to assess kidney function. It requires a urine and a little bit of blood, and so I think that's something we really need to have that community focusing on, is looking to see how these medications may improve end organ damage in that sense. Tangela mentioned a clinical trial. We were actually working with the sponsor who makes mitapivat, which is a pyruvate kinase agonist that stabilizes hemoglobin. And they had a clinical trial planned for kidney disease in sickle cell patients. But part of the difficulty is we don't have clear endpoints. And so as studies started coming out and they started seeing this huge variability in albuminuria, which seemed like the most likely target for a clinical trial endpoint, they realized that they weren't powered to do this from their studies, so they actually decided to shut down the study after kicking the can down the road for about a year and a half with us ready to go. And that's why I said I didn't want to talk about it. But there is, I think, need to evaluate this in ongoing studies. And lastly, we have this explosion of CKD modifying therapies, but again, we have no idea how they perform in sickle cell patients. SGLT2 inhibitors have been a game changer in the chronic kidney disease space. But they do have a mild diuretic effect, and so how that affects patients with sickle cell disease, where we typically try to avoid diuretics, we don't know. We are starting to use them in a lot of patients, but again, lacking data on their benefit. There is potential mineralocorticoid receptor agonists could be helpful in this population, but they are prone to hyperkalemia, as I mentioned, so we have to be careful with those. We have no idea what GLP-1 agonists are doing in this population. And lastly, we now have endothelin receptor antagonists, and endothelin is sky high in our sickle cell population and certainly does mediate some of that kidney disease, so another space for potential interest. There is hope, though. So as Dr. Campbell is part of this, as am I, and as well as another nephrologist in the UK and several hematologists. But the Kidney Health Initiative has partnered with ASH, the American Society of Hematology, and is now trying to work through identifying the natural history of kidney disease and sickle cell disease a bit better than we have so far, but also now trying to see if we can try to identify clinical trial endpoints. This is obviously going to be a big effort and ripe for lots of complicated analyses and statements that we probably lack data, but I think will hopefully get us headed in the right direction. I know I'm short on time, so I'm not going to go through this slide, but I included this because it's a great review and sort of thought process on how to assess kidney disease and manage it in the sickle cell population. So it should hopefully be in your handouts. And with that, I'll thank everyone for your patience and take questions.
While Dr. Donald is pulling up his slides, so a reminder, send in your questions or write them down. I saw lots of photos being taken, so I know everybody is really enthusiastic about the materials that were just covered. And so also wanted to acknowledge Dr. Campbell, who is the president of NKF. So thank you for being here. I failed to give you your appropriate shout out in the beginning. I was fighting the max. So thank you for being here. Thank you.
I can't do two things at once. I have to make sure it's up. All right. Hello, everyone. It's great to see you. My name is Dr. Chancellor Donald. I'm a hematologist and medical oncologist here in the city at Tulane. This is my first time here at the National Kidney Foundation meeting, so thank you, Dr. Purnell, for having me. I always like to read the room, so because this is my first time here, I'm curious. How many APPs we have in the audience? Excellent. How many physicians? All right. I love it, dude. How many physicians in training? Okay, wonderful. How many patients are patient advocates? PharmDs, old Gabby? All right, sorry to shout you out so strong. All right, and do we have anyone from New Orleans? Okay, my people are here. All right, excellent. So I want to read the room because if we're talking about equitable care, equity is always relative to something else. It's not the same idea of just giving everything equally. You have to take into account the entire picture. So it was no way I felt as a hematologist that I could talk about equity in sickle cell disease without talking about sickle cell disease. So this is going to be somewhat of a 30,000-foot view in this conversation, but I am going to sort of bring it home as far as how we all can contribute to the equity of patients with sickle cell disease and focusing on patient-centered care. I have no relevant financial disclosures regarding ineligible companies. The objectives of this conversation, I hope that you are able to demonstrate knowledge of the pathophysiology of sickle cell anemia, as well as demonstrate knowledge of the treatment of sickle cell anemia, and then lastly, identify strategies for equitable care of individuals with the disease. So we just had a wonderful presentation with the nuts and bolts of the care of patients with sickle cell anemia with renal disease, but I really want to pull back and talk about this on a much larger scale. When we talk about sickle cell disease, this is the most common inherited blood disorder on earth. I want you to keep that in mind as we talk about equity. It affects millions of persons worldwide. It affects over 300,000 births per year. Here in the United States, the disease prevalence is approximately 100,000 with an approximate age of survival of 42 years old. As far as births, 1 in 365 African American births are affected by sickle cell disease, and sickle cell trait, having just one copy and not the disease itself, affects 1 in 100 persons of Latino descent and 1 in 12 individuals of African American descent. So when we talk about sickle cell disease, I think a lot of us think of the pain crisis, so severe pain, organ damage, stroke, life-threatening infections, and sudden death. But again, because we're framing things, I want to pull back and just talk about anemia a little bit. So very classically, anemia, we think of it in different buckets. So we can have acute blood loss, so think of that trauma patient that comes in with bleeding. We can have underproduction of red blood cells or erythrocytes, such as iron deficiency anemia or anemia associated with renal disease. But we also can have destruction of those erythrocytes or those red blood cells. And we characterize those as hemolytic anemias, which we're going to focus on. So when we think of hemolytic anemias, we put them in two different buckets. Those that we are born with, hereditary conditions, and then acquired conditions. So we have hemoglobin defects, which we're going to talk about, that protein inside of that red blood cell that binds with oxygen. That's the setting of sickle cell disease. There's other conditions such as thalassemia. We can have other things affecting that erythrocyte, such as membrane defects, enzymes defects within that cell, such as G6PD. And then we have acquired defects, such as paroxysmal nocturnal hemoglobinuria, immune issues, trauma, infections, as well as toxins that could be a problem. So as we've already mentioned, we're talking about hereditary hemolytic anemias, and sickle cell anemia falls in the bucket of an abnormality of the hemoglobin molecule, protein itself. So if we're talking about an abnormality of the hemoglobin protein, well, let's talk about what a normal hemoglobin structure is. So that's a tetramer of 2 alpha and 2 beta globin chains, and we call that hemoglobin A. So if we have hemoglobin A, that means that we likely have other subtypes, and we do. The main thing I want you to take away from this slide is that you'll notice that that line represents birth, that vertical line. So before we are born, we have a majority of fetal hemoglobin. Fetal hemoglobin has a higher affinity of oxygen, which makes sense because as we are in the mother's womb, we do not have air exchange through respiration. So our blood needs to pull that oxygen molecule off of our maternal blood in order to facilitate tissue oxygenation. After we are born, you'll notice a precipitous drop. Once we get to about 1 year old, fetal hemoglobin is not normally continually produced. And again, I'll reference this a little bit more later. Okay, so we mentioned hereditary, so we're talking about genes. So if we have the hemoglobin genetics, we look at chromosome 11, which houses the genes that encode for the different proteins. We have gamma, delta, and beta on chromosome 11. And chromosome 16, we have alpha 1 and alpha 2. And different combinations of those two give us the different subtypes of hemoglobin. So when we talk about a hemoglobinopathy, something that is wrong with that hemoglobin, it can be a genetic defect resulting in the structural abnormality in one of the globin chains of the molecule, so a qualitative defect. And this can be due to a substitution, deletion, or abnormal elongation of the globin chain. And this may affect that alpha unit that I showed, the beta, gamma, or delta. So this is just a flashback. So when we're talking about hemoglobin in the setting of sickle cell disease, we have a problem with that beta subunit. And what happens is that we have a point mutation that is a substitution of glutamic acid with valine on the 6th position of the beta globin chain. This causes a steric or conformational change in the molecule itself. It then polymerizes when that red blood cell is deoxygenated, and that's when we get the classic sickle cell that is rigid. That rigid cell causes sickling in the microvasculature bed as we go through smaller capillaries. We then get occlusions, and if we have vascular occlusions, that means that we're dealing with ischemic tissue damage. Okay, so we had a wonderful presentation before telling us about the specifics of renal issues in our patients, but I'm going to talk about overall clinical interventions. So, of course, these patients can be functionally asplenic, so prevention is a big deal, so immunizations is key. We also give our pediatric population prophylactic penicillin. In places of the world where it is endemic, we have malaria prevention. We give folic acid, of course, for hematopoiesis, blood transfusions for support when needed. Very rarely we do bone marrow transplantation. We do now have gene therapy on the horizon, which I'm going to talk about in a little bit. And then, of course, we have different therapeutic medications. But before we go on, just to ensure that you're not just enjoying my North Florida accent and you're actually listening, there is a poll. So if we're talking about sickle cell disease, what type of anemia is it? Is it acute blood loss anemia? Is it an underproduction of erythrocytes? Is it a hereditary hemolytic anemia? Or is it an acquired hemolytic anemia? You guys are wonderful. 100%. How awesome is that? Good job. Up, 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 up. Wow, wow. It's always one. All right. So, talking about clinical interventions again, we're going to talk about the therapeutics. Now we're going to get into disparities because I want you to realize that this is the most common inherited disorder on earth. This is the complete list of FDA-approved medications for this illness. Let that sink in. The first molecularly described disease that we saw at the genetic level. And these are the therapeutics that we have in place. But it gets worse.
This is only recent, too.
As I'm about to show you, sir. In 1998, we had Hydrea. As this astute gentleman just pointed out, you see the most recent advancements come within the last 7 years. So we have L-glutamine powder, we have voxelotor in 2019, crizolizumab in 2019 as well, exagamglagine in 2023, that's the CRISPR therapy, and lovotibeglogene, which is the viral vector therapy. But it gets worse. 2 of these medications have been withdrawn off of the market. Voxelotor was withdrawn from the global market in 2024 due to increased adverse events, and crizolizumab was withdrawn from the European market in 2023 after subsequent studies showed that it was not statistically significantly different than treatment with placebo. And this has also limited its use in the United States. So, when we talk about hydroxyurea, which has a plethora of effects, we see we see improvement in renal function in some of our patients who are on this medication. But the main reason it got its approval was because it showed a decrease in vaso-occlusive crisis in patients. This was back in 1995. But because I have trainees in the room, remember, we dig into the data. We remember that statistical significance doesn't always equal clinical significance. And we have to be sure that we're actually getting the outcomes that we're hoping for as it applies to our patient population. So within this study, if you look at results, the patients who received hydroxyurea had lower annual rates of crisis than placebo, a median of 2.5 per year versus 4.5 a year. So an improvement, but of course not at all a home run. And then we have L-glutamine. L-glutamine was approved, as I mentioned, in 2019. And if you kind of jump in here, the patients, on the results, the patients on L-glutamine had statistically significant fewer pain crises than the placebo group, with 3 happening in the L-glutamine group and 4 happening in the placebo group. 1 less pain crisis. Okay, exagamblogene autoleucel. So this was a very exciting time for us as hematologists. They actually announced this during the first weekend of ASH back in 2023. So you had a room full of excited hematologists. The first CRISPR therapy ever is applied to this disease that has been historically neglected. We were very excited about this. And if we talk about what it is, it's a cell-based gene therapy that's approved for our patients with sickle cell disease. So I'm happy to talk to persons afterwards because I want to be respectful of the time. But this is a gene editing technique that actually goes in, and it doesn't fix that substitution that makes the disease. I want to be clear. What it does is it activates the reproduction of fetal hemoglobin. So remember I mentioned before that when we turn 1 year old, that decreases? Well, this CRISPR therapy causes that fetal hemoglobin to be produced again. And as far as outcomes, remember the meager outcomes we've had in the other trials? Using an endpoint of severe vaso-occlusive crisis and freedom from these crises over 1 year, they saw that 93.5% of the patients who received this therapy had freedom from vaso-occlusive crisis from 1 year. This is awesome. And then if we look at lovotibeglogene, which is a viral vector therapy, also received this approval on the same day. Both announcements happened simultaneously. Lyfgenia is the trade name of lovotibeglogene. It's a cell-based therapy, but not CRISPR. This is a viral vector therapy that goes in and inserts the genetic material for the production of hemoglobin A. But it's a special hemoglobin A that can be noted on electrophoresis. It's hemoglobin A T87Q. And again, this is just so we can identify, but it is 99% similar to the normal hemoglobin A that we produce. Okay, using the same outcome, freedom of vaso-occlusive crisis between 6 and 18 months, 88% of the patients. Absolute home run. I would be remiss if I didn't mention bone marrow transplantation, which has been around for a while. This is when we have a healthy donor, so someone without sickle cell anemia. We have that patient with sickle cell anemia that gets a regimen that wipes out their marrow. We give that person with the wiped out marrow the donor's hematopoietic stem cells that infuse into the patient and then produce normal hemoglobin. This is rarely done throughout our country. I've look back through Tulane, I think we've had 1 done in 15 years. So not common. Okay, we're talking about equity. So what challenges do we face? So too often our patients with sickle cell anemia do not receive comprehensive, high-quality health care that they need. We have data, and it was touched on earlier, that multidisciplinary care improves outcomes and mortality rates in our patients. But we don't have this as a result of healthcare work shortages, lack of providers educated on sickle cell disease, irrefutable acts of racial bias and discrimination, geographical barriers, and other challenges related to the social drivers of health. To complicate this even more, about half of the persons with sickle cell anemia are on Medicaid. Now, we're providers in this room. I forgot to shout out the nurses in the room as well. But we're providers in this room, and if we're honest about things, we know that there are institutions, practices, and providers that limit the amount of Medicaid patients they care for. So this is also problematic. 78% of Medicaid beneficiaries had one emergency department visit in 2017, and almost half of the beneficiaries with sickle cell disease had at least one patient inpatient stay. Okay, so we described the problem. Let's talk about solutions. I was fortunate enough to be one of the reviewers for the National Academy of Sciences in Engineering and Medicine document to comprehensively address sickle cell disease. This gives a strategic plan and blueprint for action. This is available to be downloaded if anyone is interested. This is a bit of a busy slide, but I think it helps drive home the point. At the top, you see organization and integration of care and services. So on one side, we have the community, patients and families affected by this illness, and then we have the healthcare system. As far as our patients affected and their families affected by this illness, educational, recreational, vocational, and disability support is ideal. On our side in the healthcare system, patient-centered healthcare is ideal. And the intersection of these two should yield patient and families that have the ability to self-manage themselves with support. And then further down, if we talk about that sort of loop of things that would improve outcomes, informed and engaged patients and their families, along with supportive, integrated communities, and prepared, proactive practice teams in place. These things are all very important, with the idea of yielding optimal patient and functional clinical outcomes. So this is also a bit small, but I just really wanted to show the intersection of these things. If we're truly talking about getting there, delivering high-quality sickle cell disease care with a prepared workforce, we can do certain things. We can have sickle cell disease core sets that address some of the issues that I've mentioned in my presentation already. Of course, pain management, the limited disease-modifying treatments that we have, consideration of prevention of VTE because our patients with this hemolytic anemia are at increased risk for thrombosis, newborn screening, genetic counseling. But as was previously mentioned, don't forget that these are still patients that can develop other conditions. We cannot get myopic because we will miss things. So consider the other things that they could get as a normal adult population if you treat adults, because we know hypertension complicates sickle cell nephropathy as well. So all of these things are important for us to address, and we don't want to forget our persons with sickle cell trait to make sure they have genetic counseling, for them to watch out for hematuria. Unfortunately, renal medullary carcinoma is something that we see in this patient population, and we have to be hypervigilant about that. And of course, adequate hydration for our Army recruits, athletes, and persons undergoing strenuous physical activity. So, how do we advance equity and patient-centered care for our patients with sickle cell disease? With understanding. Understanding that this is the most common inherited blood disorder on earth, with less than a handful of disease-modifying therapies. Understanding that half of the patients in this country are on Medicaid, which can also restrict their access. Understanding that this is something that affects entire families and communities. Understanding when we're at that bedside dealing with someone who quite honestly could be difficult, who could have other problems on top of this. To understand the historical nature of this inequity. And I think everyone in this room is taking that step by being in this room to get a deeper understanding of this illness. I thank everyone for their time and attention.
Wow, that's all I can say. Please have a seat.
Coach, if you're going to join us, sir.
Oh, yeah, I may, but no, have a seat. Yeah. Yeah. I want you to be comfortable. No, please again join me in thanking both of our speakers. Who is mad? After hearing all this data, da 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 da, lots of pictures. Anybody mad? Anybody upset? Yes? No? I see some head nods. Yes, I'm mad. I'm mad. I'm a lot of things, but it's not the me show today. It's the you show. And with that being said, we have our first question.
Hi, thank you so much for an excellent session. My name is Deepal, and I'm a nephrologist at Johns Hopkins. We very recently started a multidisciplinary clinic with hematology, and I was very quickly awakened to the fact that I know practically nothing about treating patients with sickle cell disease, despite having attempted to read about it and do my due diligence. And so something that came up very quickly was just that sickle cell disease is so heterogeneous in terms of genotype, but even clinical outcomes in terms of how frequently patients are experiencing crises. So how do we take that to then decide what treatments patients may be eligible for, especially when we think about SGLT2 inhibitors and GLPs? And then also thinking, like, if we were to design a practical trial in clinical care, a pragmatic trial, what sort of patient outcomes are the most relevant to the patients? Because I was kind of shocked about how much people cared about their albuminuria, despite having so many other things that I would have felt were more important to them. But I'm curious if patients have ever been asked sort of what's the most important to them.
Yeah, please, go ahead.
I would like to speak from the perspective of being a medical oncologist as well. Because in medical oncology, we truly look at that patient from the molecular standpoint, right? So it's not just lung cancer. We take it down to the histology of non-small cell versus small cell. And then from there, is it adenocarcinoma if it's non-small cell? And from there, is it ALK positive if it's EGFR positive? And all of these things are both predictive and prognostic biomarkers, predictive of response to therapy and prognostic of how well patients would do overall. Again, talking about the overall tragedy of sickle cell disease is that we don't have prognostic markers. We don't know what person is going to do very well with sickle cell disease and ultimately what person is not going to do well. We do not have that tool set from simple serum tests all the way to the molecular level. Yes, there have been things that tend to predict things such as leukocytosis can predict if someone would have a complicated course as a pediatric patient, but it is nowhere to the point of precision and accuracy that we see in the other field of medicine in which I practice. So to answer your question directly, we do not have a clean prognostic marker or predictive marker to see how well those patients would do. If you're asking more about what matters to them, I would venture to guess really what matters to someone, whether their medical literacy is 0 or 100, is debilitating pain and complications. We can look at some of these markers. If, in fact, one of the drugs that I didn't talk about much, voxelotor, because it was pulled off of the market, that clinical study didn't look at vaso-occlusive crisis. It looked at hemoglobin response. So that was the endpoint, if there was a 1 gram increase in the hemoglobin over 26 weeks. I don't know how much that means to patients if they go from 5.5 to 6.5. I don't know how much that means if they go from 8.5 to 9.5. But I do think freedom from vaso-occlusive crisis is a big deal. And then once we start to look at that, we can look at the other things, because we know hemolysis itself is a problematic event. We know it's nephrotoxic. We know that it causes blood clots. We know that it causes all these other issues. So that's something else that we could look at. But as you can see, your question points to the inequity of care in a disease that affects most people on earth.
That's great. Thank you. I'm looking at the app, and thank you all. You followed instructions, and we have 5 minutes, so I don't know how we're going to get through all of these. But I'll start. Is there any data on mortality in sickle cell disease patients receiving transplants beyond 90 days, such as greater than 1 year? I can quickly add yes. In fact, we conducted a survival benefit analysis that was published in C. Jason. The lead author is Sanjay Bay. I'm the senior author, and we used data up to 10 years post-transplant and still found that there was a survival benefit of transplant. So I can quickly answer that one. Is there a difference in outcomes for PD fistula graft compared to catheter-delivered HD?
No, it's on. So again, we don't have great data because people haven't looked at this well enough, but generally speaking, I think the couple studies that have been done suggest that there is potentially a mortality benefit from PD. There are certain things that become matters of convenience for some patients because if we have a hemodialysis access, it makes it very easy to do exchange transfusions for patients. And so there are sometimes a lean towards pushing patients in that direction. We have tried really hard to push home therapies for the majority of our patients if we think they have the home structure to be able to support it. And some of our patients, weirdly enough, at one point I was our medical director for home therapies and was doing the sickle cell clinic and a vasculitis clinic, and I had a patient who had all three of those problems. But it opened up my eyes because you really can get most patients to do home therapies if you really just have the support structure around them, and that's difficult. But there is potentially a clear benefit there. No one's really, to my knowledge, looked at the benefit of graft versus fistula, but I think it would probably play out the same. One major issue we run into with fistulas is if those fistulas get really big and you end up with at least close to high output failure, a lot of those patients already have pulmonary hypertension and are taxed, and so that can be a real strain for them. So we struggle with our vascular surgeons sometimes being willing to reduce or ligate those fistulas because they're not convinced, because it doesn't look as bad as it does in the usual dialysis patient, but it's producing a lot more stress on that patient because of their sickle cell disease and pulmonary hypertension. Sorry.
With so many of the patients being on Medicaid, does that prohibit them from receiving some of the newer advanced therapies, such as the ones that you mentioned work well in preventing the pain crises?
Yeah, I was waiting for this question. A little audience participation. The CRISPR therapy, somebody throw out a number how much it costs for treatment for a patient.
Million.
Higher.
Get out of here.
So $2.5 to $2.7 million.
Man, who paying for that?
Not Medicaid.
Not Medicaid. So this is an issue that we face. Yes, this is staggering. My hope is that we get better uptake. I am proud to say the system that I'm part of, LCMC, did treat a patient here on Medicaid with the CRISPR therapy. He was just released from the hospital last week. We have 5 people in the pike to get it as well. My hope is that, sometimes list price isn't the effective price, but I doubt if something is listed at 2.7 that they're selling it for $50.
Is there a difference in progression of CKD with different genotypes, phenotypes of sickle cell?
Yeah, so I think I showed that in one of the studies, but I had way too many slides, so apologies for running through this so quickly. But in patients with SS or beta-zero thalassemia, they seem to have the most severe phenotypes in general, but particularly in the kidney, they tend to progress faster and have more kidney disease. We do see, and this is my anecdote, so I have a set of patients with SC disease, so what we typically think of as a less severe phenotype, who have kidney disease that is progressive without albuminuria, and we have no idea what's happening there. So I think there's a lot still to learn about this, and I guess the first question raises a great point that there is so much heterogeneity in this population that has been understudied that we really don't know exactly what we're looking at. We're trying to lump everyone into one bucket, which doesn't make sense.
All right, thank you. And that puts us right at 5 o'clock, so we are ending right on time. Again, please help me to thank our multidisciplinary panel. We walk it like we talk it, right? So, and again, hope that you're ready to leave out of here. I hope that you're mad. I hope that you're pissed off. But more importantly, I hope that you're ready to go fight as hard as those gnats were fighting us at the beginning of this talk. Go fight for the patients. Thank you very much for coming.